to improve patient outcomes. John rolled up his sleeves, designing sessions, contacting potential speakers, and cheering everyone on to success. John, we could not have done this without you. Come on out.
Thanks, Kent, Mark, and Gloria. I've enjoyed working alongside you to present this fantastic program. It is now my pleasure to introduce our first plenary speaker, Dr. Steve Webb. Dr. Webb is a senior staff specialist in intensive care medicine at Royal Perth Hospital. He's a professor of critical care research at Monash University and a former chair of the ANZIC's Clinical Trials Group. Dr. Webb designs and conducts trials that generate evidence to improve patient care. He's been the recipient of more than $85 million in research funding and has published over 140 manuscripts in high-impact journals that include the New England Journal of Medicine, JAMA, the British Medical Journal, and the Lancet. His work has been cited more than 23,000 times. Steve led time-critical observational studies during the 2009 H1N1 influenza pandemic and is contributing to the creation of a global platform that will allow the conduct of randomized controlled trials during a future pandemic of severe acute respiratory illness. On a personal note, the first time that I met Steve, I watched him diagram out a viable and interesting study design from scratch while we were watching a presentation. Today, Dr. Webb will present Pandemics Cross Borders, How to Tackle Them from a Global Perspective. Ladies and gentlemen, Dr. Steve Webb.
Thank you for that welcome, and thank you, John, for that very kind introduction. I provide my disclosures so that they're available on the public record. So, this is our spaceship. There's 7.6 billion of us travelling through space on this rock. As you look at this particular view, you can see Central Asia, the Indian Ocean, and if you peer down just into the bottom right-hand corner, you can see the west coast of Australia, which is where the city of Perth is, which is where I hail from. It really is an enormous privilege and honour to be on the other side of the planet, here in San Antonio, speaking to you today. And I want to thank the Society for Critical Care Medicine for the wonderful and very much appreciated invitation to be here today. So for the 7.6 billion of us who are travelling through space on this rock, there are relatively few events that represent a major threat to a large proportion, a large substantial number of people who could die from such an event. We're unique among species in that we've acquired the capacity to wreak our own destruction. An asteroid impact is an existential threat. Such events have occurred before. They've changed the course of evolution. There's now a substantial effort underway to track and identify asteroids that might collide with the planet and be able to mitigate that risk. But the threat that is regarded as the one most likely to result in more than 10 million deaths is a tiny microscopic threat. It's influenza or some other pathogen with pandemic potential. And this is our existential threat. This is critical care existential threat. It belongs to us. And that's because pandemic influenza will bring large numbers of critically ill patients, possibly very large numbers of critically ill patients. Every winter, there are outbreaks of seasonal influenza. One or more strains circulate, and each year the virus bounces between the northern hemisphere and the southern hemisphere. And as it bounces around, it acquires small mutations on its surface antigens sufficient to result in next season's strain of influenza. And this is called antigenic drift. These are very small changes. And most of the population has reasonable degree of pre-existing immunity. It doesn't mean that influenza doesn't cause critical illness, it does, particularly in the elderly and in very young children. And as I understand it, this has been a very busy winter in the intensive care units of North America with a lot of seasonal influenza. But at irregular and unpredictable intervals, something very different happens. What that something is a major change in the antigenic structure of the surface antigens, and that's called antigenic shift. There are lots of strains of influenza circulating in animals, and occasionally what happens is one of the surface antigens that are on those strains is able to combine with another strain that results in a major change in the surface antigens. And this creates a completely new strain. Most of the population have no pre-existing immunity, and that has two consequences. The first is that it creates a virus that's capable of enormous and rapid spread. It will spread around the globe. Epidemiologists refer to a thing called the reproduction number, which is the number of new individuals who will acquire an infection from an already infected individual. And when that number is more than one, the virus will spread as a pandemic. The other thing which occurs is that it results in much more severe illness. Typically, it affects young, fit, previously well people. It results in bilateral viral pneumonia or secondary bacterial pneumonia with respiratory failure and often failure of multiple other organ systems. And so a pandemic requires antigenic shift combined with a virus that's capable of sustained transmission amongst humans with a reproduction number of greater than 1. And this happens, on average, every 23 years. In the last 280 years, there have been 12 pandemics. The smallest gap between pandemics is just 6 years. The largest gap, almost 50 years. And the public health significance of when one of these new pandemic strains occurs can vary enormously. The last pandemic was in 2009. It seemed to come out of nowhere. It came out of Mexico. It spread to North America and Canada, to US and Canada quite quickly. But because it was spring and weather was warming, transmission petered out, and what it did was it went south. It went to Australia, which is why you're listening to someone with a slightly strange accent. It came to Australia as a wave that moved around the various regions in sequence. My own ICU, the Royal Perth Hospital Intensive Care Unit, at its peak, we had every bed occupied by a patient on a mechanical ventilator, and over half of those patients had documented H1N1 influenza. But just when we thought the ICU couldn't take any more strain, the number of new cases dropped, and we were able to cope with the existing resources that we had. It's an aside, but a worthwhile one, that our health department had indicated that their plan, if we ran out of bed spaces, was to open a strategic reserve of ventilators and other equipment and monitors, and to set them up on wards and have floor staff look after ventilated patients, without understanding that that wasn't going to be a very good plan. But in the end, in retrospect, 2009 turned out to be a fairly mild pandemic. It started with headlines like this in the Evening Standard in London. And a year later, these were the headlines in the United Kingdom, that it was a fizzle. And as is often the case, The truth lies somewhere in between. Probably around 100 to 200,000 people died globally from the 2009 influenza pandemic. A lot of those deaths occurred in low and middle income countries. In the countries that do have provision of critical care services, maybe 200,000 individuals were mechanically ventilated for H1N1 pneumonia. So this wasn't a trivial event, far from it, but it certainly wasn't a global catastrophe either. But influenza can result in much, much more severe pandemics. In fact, this is the 100-year anniversary of the last devastating pandemic. The 1918 Spanish flu followed World War I. The exact death toll is not known, but perhaps bottom range estimates are 50 million deaths, maybe as many as 100 to 200 million deaths. The global population at the time was 1.8 billion. There were estimated to be 500 million people infected. And if you do the maths on that, the best estimate is 3 to 5% of the global population died as a consequence of antigenic shift occurring in an influenza virus. It demonstrates the capacity of influenza to create, through antigenic shift, a new virus that is capable of spread. The reproduction number of the 1918 virus was probably about 2. And it demonstrates the capacity of that virus to be extremely virulent with respect to its capacity to cause critical illness, which of course in 1918 was fatal. Overall, case fatality was probably around 10 to 20%. And so what would happen if a virus turned up in 2018 with the same virulence as the virus that occurred in 1918? Well, capacity to spread is probably diminished. We live in much less crowded living conditions, we're healthier, we have better diet, and we know a lot more about how to contain spread. It's also the case that I'm sure case fatality would be much, much lower. The availability of antibiotics to treat secondary bacterial infection, notwithstanding the controversy, the availability of antivirals, and of course the provision of critical care. Nevertheless, influenza, an influenza pandemic, is the event still regarded as the threat most likely to cause more than 10 million deaths. And a critical feature of all pandemics is uncertainty. Uncertainty about when it's going to happen, where it's going to start, and how bad it's going to be. So research can and should serve to resolve such uncertainty as quickly as possible. The information is needed by clinicians who are going to care for these patients. That information is needed by us, and it's needed by public health authorities who need to make decisions regarding public health measures. There are key questions. How severe is the pandemic? Public health authorities around the world, including in this country, were criticised in 2009 for overreacting. I think that's an unfair criticism. They had to make decisions in a fast-moving environment with very limited information, and it was probably better that they overreacted than underreacted. One of the best measures of how severe a pandemic is going to be is how many patients end up being looked after by us. How many patients are actually critically ill? We need to know things like the case fatality rate, and the people who do mathematical modelling to predict where the epidemic is going to go next need to know the reproduction number. But as a clinician who cared for patients early in the 2009 pandemic, it was extremely frustrating looking after this new disease with no idea what other clinicians were seeing, with no idea really of the way that this thing presented, how it progressed in terms of organ dysfunction, what were the complications. Just basic knowledge that we take for granted about other diseases was not available. We also had issues around how good the diagnostics were. My infectious diseases and microbiology colleagues were confident that PCR was 100% sensitive. I could tell them at the bedside that it wasn't. And very important for all of us who care for such patients is knowing whether or not the infection control measures are going to be sufficient to protect us and to protect our families when we go home from work. And ideally, we want to know what treatments work best. We accept that randomised controlled trials are the way of generating the best quality of evidence. But there are unique and enormous challenges associated with being able to try and conduct randomised controlled trials during a pandemic. So the premise is this. What's happened in previous outbreaks is that there's a timely basic science response. These pathogens are identified quickly, their strain structure is identified, their genomes are sequenced. There's a timely public health response from the very beginning, but a delayed clinical research response. Our premise is that if we can ensure that a clinical research response can be launched early in a pandemic, that the information that comes from clinical research is capable of changing the trajectory of a pandemic. So we had a dress rehearsal in 2009. We tried to do research and we largely failed last time around. And this is a story that I think illustrates why it is so difficult to conduct research in a pandemic, which turns up in a matter of weeks or months. A colleague of mine, Peter Kruger, wanted to study the pharmacokinetics of oseltamivir in critically ill patients because there was no information about it. He put together a protocol quickly. He submitted it to the IRB. He submitted it to the IRB a couple of weeks into the epidemic. And they actually gave him a pretty quick response. They gave him a response of approval in 6 weeks, by which time there were no new patients. The wave had been and passed. In Australia and New Zealand, we conduct a large number of very large-scale randomised controlled trials. We have fabulous infrastructure and fabulous experience. But it's extremely rare for us to be able to get a trial up and running in anything less than 12 months. And that's just because it takes time to write a protocol, to design case report forms, to put the data management together, to obtain IRB approval, and to obtain contracts with sites to participate. These are timelines that just can't be compressed. So in 2009, it was a research failure. There were some observational studies, but they were still slow to give clinicians the information that they needed to care for patients. In fact, 4 randomised controlled trials were funded in North America and in Europe. They were funded to recruit several thousand patients. And in total, less than 40 patients were enrolled because of these logistic issues that I talked to you about. So we need better research preparedness on a global basis before the next pandemic turns up. And to achieve this, there are 3 elements that are necessary. The first is that the research needs to be pre-planned. By pre-planned, I mean that the protocols are written, the data management is in place, the case report forms are designed. Additionally, this means that the data elements are standardised. One of the frustrations of the 2009 pandemic was having colleagues who'd also conducted observational studies, and we couldn't share data because we'd used different definitions and they were not compatible. The second component that's essential is that it's pre-approved. It's already been to an IRB. It's been through ethical and all other necessary regulatory reviews. I genuinely believe that a large amount of the data that would be needed from an observational perspective can be anticipated in advance. And similarly, I also believe that the interventions we would most want to evaluate in patients with pandemic influenza can also be anticipated in advance. To whatever extent that anticipation turns out to be incorrect, it's certainly much easier to modify and amend an existing protocol than it is to start from scratch. And the last component is that the infrastructure needs to be practiced. Practiced means that during the interpandemic period, the sites and locations that will conduct this research demonstrate themselves as having capacity and capability to undertake research. So we need sleeping approvals in place to be able to activate in the space of weeks to generate the information that we need in future pandemics. All components necessary must be put in place and then held in a state of readiness so they can be activated whenever it's appropriate to do so. A number of global and regional organisations have formed since 2009 to try and meet this challenge. ISARIC is the International Severe Acute Respiratory and Emerging Infection Consortium. It does have some critical care involvement, but it's also an involvement of infectious diseases and public health folk. The International Forum of Acute Care Trialists, led by John Marshall in Toronto, represents all of the 25 to 30 or so investigator-initiated clinical trial networks that are active in intensive care. In Europe, the PREPARE consortium is very active and is probably the most advanced of the regional consortia. In Australia, we have a prize, and in the United States, led by Perrin Cobb, there is Discovery Prep, which is exceptionally active in this area. And there are really two elements that are necessary as part of any pre-planning. The first is the capacity to undertake observational studies of critically ill patients, and that's the role of Sprint SARI. REMAP-CAP is a very ambitious platform designed to be able to conduct time-critical randomised controlled trials during a pandemic. And I'll talk about each of these in turn. So Sprint SARI has as its objective to be a global platform that can be activated to undertake observational studies of critically ill patients in the event of a pandemic. Currently, it's active in 26 countries with 140 sites. There's a common protocol, a common case report form and data dictionary, and tiers, levels of intensity of data collection that allow sites to participate if they have very little in the way of resources through to substantially more in the way of resources. There's a common data management platform, and the intention of Sprint SARI is that active sites will activate themselves for 1 week each winter and collect information on patients with severe acute respiratory illness, demonstrating their capacity during the interpandemic period. But the IRB approval sleeps, able to be activated in the event of a pandemic. And so, although this is a useful start with many countries and a large number of sites, the breadth of countries and the number of sites needs to be increased substantially over coming years to truly make it an effective way of being able to collect this crucial observational data in the event of a pandemic. But an observational study is not really going to help us determine what are the best treatments that we should be using for patients with pandemic infection. That needs randomised controlled trials. So REMAP-CAP is a novel, innovative type of trial design which is very radically different from probably just about anything you've come across before. It's designed to be able to be activated during a pandemic, but it's also active in the interpandemic period. And I do want to acknowledge, in particular, the role of Scott Berry and Roger Lewis at Berry Consultants, who are based in Austin, where I was on Friday, and also Derek Angus from Pittsburgh, who's been a major driver of REMAP-CAP. So REMAP-CAP has two objectives. Firstly, it recruits patients during the interpandemic period, identifying the optimal treatment for patients with severe community-acquired pneumonia. But in the event of a pandemic, it can adapt, and adapt is a key word in this type of trial design, to generate evidence about the optimal treatment of patients with pandemic infection. The first objective is very close to commencement of recruitment. It's been a very complicated trial to try and put together. And we'll start recruiting in Australia and New Zealand in a couple of months' time. The other objective, to be ready for a pandemic, is probably still 1 to 2 years away, but something that is being worked on very actively. So REMAP-CAP has been funded by the European Union, by the Australian National Funder, and also by the New Zealand National Funder. And there's actually a grant application pending at the moment to allow recruitment in Canada. It's currently funded to recruit 6,800 patients, and it involves the simultaneous evaluation in patients with severe CAP of empiric antibiotics, the role of corticosteroids, the duration of macrolide therapy in patients who've been randomised to a beta-lactam antibiotic because it's combined with a macrolide, and ventilation strategy in patients who have severe hypoxemia. But to understand platform trials, it's important to know a little bit about their background. The granddaddy of platform trials is I-SPY2, which is a phase 2 trial of neoadjuvant chemotherapy in women with breast cancer, now producing results in high impact journals. There's only about half a dozen platform trials at the moment, although there's a larger number under development. So, what is a platform trial? A platform trial is really a system. It's a system to optimize the treatment of a particular disease as time goes by. It's a perpetual trial that continuously updates best treatment for all patients in the platform. A conventional trial has a start and a stop, and in between there's a target sample size. Platform trials are completely different. They don't have a pre-specified sample size. They continue as long as is necessary to generate the results. In critical care, we're used to patients receiving, during the days that they spend in intensive care, 10, 20, 30 different treatments? And for each of those treatments, there are often many choices and options that would be regarded as being reasonable within the spectrum of standard care. Our current paradigm for doing randomised controlled trials is to test A versus B. It's going to take an inordinate length of time if we continue to just do pairwise questions of A and B to work out what is the best combination of these treatments for patients who are critically ill. But to explain platform trials, I need to first introduce you to some nomenclature. This is nomenclature that we've actually had to develop as part of the protocol of REMAP-CAP. Multifactorial is a long-standing term, it's not new, but it means randomisation to multiple components of treatment simultaneously. And then sophisticated statistical techniques are utilised to identify the independent effect of each intervention that's available within that multifactorial menu. The second term is a domain. A domain is a category of treatments with the same purpose for which there are mutually exclusive options, like the antibiotics that are used for empiric therapy for community-acquired pneumonia. An intervention is one of the treatment options within a domain, and the regimen is the actual individual interventions that a patient is allocated through the randomisation that occurs within REMAP-CAP. There are four design features that are critical to understanding platform trials, and I'll spend some time working my way through each of these. The first is that they utilise frequent interim analyses using Bayesian statistical methods. The second is that they're multifactorial. We are testing multiple interventions simultaneously in the same patient. The third is that we use a technique known as responsive adaptive randomisation, which means that the patients within a trial are actually benefiting from the data that's already been accrued. And fourthly, we have the capacity to evaluate differential treatment effects. I'm certain that in critical care we've abandoned interventions before because in one group of patients there was benefit and in another group of patients there was harm. And when we analyse all of that together, the effects neutralise each other and we have trials that show no difference. The first one that I want to turn to is the frequent interim analyses using Bayesian statistics. It's a feature which is unusual in a trial because we're used to models in which you can't analyse a trial until you've finished it. And this is different in platform trials. You are able to legitimately analyse as the trial proceeds. So this is what happens in a traditional trial. You set it up and you start to randomise. You're young, you're fit, happy. You continue to randomise, you put a little bit of weight on. You wait, you get a lot older. And then hopefully you get to finish before that happens. But when you do get to the magical sample size, you get to analyse. And I've sat around the computer of these big RCTs as you spit out the chi-square value to determine whether or not the last 5 years have been worthwhile. And when you get to analyse, there's one of two possible results. Hallelujah, you've got a p-value of less than 0.05 and the magical threshold has been beaten. And you've achieved difference. Or the p-value might be over 0.05, in which case it's interpreted as showing no difference. But frequently, trials that show no difference are better regarded as being indeterminate. It truly may be that there's no difference between option A and option B. But it's also the case that the trial might have been underpowered and the plausible effect size was overestimated, and there's still the possibility of clinically relevant difference. Or, as I indicated before, there were subgroups. Some were benefiting, some were harmed, and overall as a package, there's no difference. And what's more, it might have been that the outcomes of that trial might have been known substantially earlier, well before the trial finished recruiting. So platform trials use frequent interim analyses using Bayesian statistics. Bayesian statistics take a prior probability, and in REMAP-CAP, our very first analysis starts with an uninformative prior. So we're not influenced by anything that's preset. And Bayesian statistics ask the question, if you add to the prior probability, what data has accumulated since the prior probability was calculated? What is the new posterior probability, which is an analysis that provides the updated probability that an intervention is either superior, inferior, or equivalent. So what happens in a platform trial is that we use frequent interim or adaptive analyses to answer a question as soon as there is sufficient statistical confidence to back that answer, not when you hit a pre-specified sample size. So you randomise and analyse, you randomise and analyse, and you randomise and analyse as you go. And through a miracle, you stay young. And when you randomise and analyse at each of these interim analyses, there are two possibilities. An intervention might be inferior, superior, or equivalent, and that's a statistical trigger, and it allows a conclusion to be drawn. Or you simply continue recruiting until you've achieved either difference or equivalence. What this does is it eliminates indeterminate results. The second design feature of platform trials is that they are multifactorial. The initial stages of REMAP-CAP are to plan for 5 domains of care. They are the choice of antibiotic, the choice of empiric antibiotic, whether or not to use hydrocortisone, whether to continue macrolide for as long as 14 days to take advantage of its potential anti-inflammatory effects, the ventilation strategy in patients who have severe hypoxemic respiratory failure, and the optimal oxygen saturation target that we should be aiming for in patients. And the trial adapts. It provides randomization allocations in parallel for an individual patient, and in sequence as the trial evolves, the domains and interventions within the trial change. depending on the results that have been generated. So at launch, we actually have 4 empiric antibiotic options. Added to that list now is coamoxiclav. And what I'll do now is just give you a little bit of an idea of one of the theoretical possibilities that might occur in REMAP-CAP. There are many, many different directions, and the directions will be determined by the results as data accrues. Let's say it turns out that ceftriaxone plus macrolide turns out to be the best antibiotic. What happens within REMAP-CAP is for all appropriate patients, they now receive that as an allocation. So not only are we generating evidence, but within the platform we are also implementing the evidence that has been generated. If you recall, the steroid domain started as steroid and no steroid. In this theoretical example, what's happened is that it turned out that steroids were best, and we're now randomizing patients to short versus long course. In the macrolide domain, it turned out that long macrolide was best, and now everyone's getting 14 days of azithromycin. In the ventilation domain, we started with 3 interventions: conventional ventilation, extracorporeal CO2 removal, and APRV. As it's turned out, conventional 6 mils per kilo turned out to be inferior. So it's been dropped from the platform. Patients are no longer being allocated to an inferior intervention. But we continue the trial, narrowing down progressively to determine whether APRV or ECOR is the best treatment. Now, at the beginning of REMAP-CAP, we're not going to give clinicians any guidance whatsoever about oxygen saturation target. It's a silent domain. It's sitting there in the background, yet to be activated. And the reason that it's silent is my colleague Paul Young in New Zealand is still completing the ICU ROC study. But based on the ICU ROC study, we'll introduce a domain with 2 different saturation targets. And so you can see, as time rolls through and answers are generated, the trial structure evolves, the domains and the interventions change. I said the third feature of platform trials was response-adaptive randomization. To understand response-adaptive randomization, I'll just remind you about traditional randomization, which is a fixed 50-50 split of patients between 2 interventions. It starts that way at the beginning of the trial, and it's exactly that way when the last patient is recruited into the trial. What response-adaptive randomization does is it actually gives patients some skin in the game. They're not dumb participants, they're not guinea pigs. They can actually benefit from the data that has already been accrued within the trial. So we start with 50-50 randomization, but at some point a group starts doing better because it is better, and then we progressively send more patients to the group that has the better outcome. What this means is that within a trial, over the lifetime of the trial, is mortality is actually lower within the platform than would have been the case without response-adaptive randomization. And the last feature is the capacity, if a variable is specified as a pre-trial strata, a pre-trial subgroup, there is the capacity to identify differential treatment effect. In REMAP-CAP, we divide patients based on whether or not they are in shock or not in shock at time of enrolment as our first strata. We don't, with 6,800 patients, believe it or not, have sufficient sample size to run with more than 2 strata. But over time, as we build the number of patients that come into REMAP-CAP, we will aim to add additional strata. What the Bayesian statistics do is that they analyse each strata, shock and non-shock, separately. And if the effects are congruent between shock and non-shock for a particular intervention, then the sample sizes are effectively joined in a process known as borrowing, so that statistical confidence about the treatment effect of an intervention comes from the entire sample. Whereas if treatment effects are discongruent, if they go in opposite directions, then each strata is analysed independently without there being any evaluation from the other strata. And this has the capacity, if the strata have been chosen wisely, to avoid the circumstance where trials show no difference because one group benefits and another group is harmed. We're not sure. We think the efficiencies that accrue from stopping recruitment as soon as you've got an answer and from being able to randomise patients to multiple domains of care simultaneously mean that the efficiency gain is somewhere in the order of 5 to 10-fold over conventional designs. And I want to now run through why this is such a fabulous design for a pandemic. In a pandemic, there is a lot of uncertainty and it's a fast-moving, fast-changing situation. And an adaptive clinical trial allows us to modify the trial based on the features of the pandemic. The capacity to analyse as we go means that we generate answers quickly as possible. The response adaptive randomisation means that if there's an intervention that improves outcomes, during the trial, progressively more patients receive that intervention, and when it hits a statistical trigger, 100% of patients receive that intervention. And we can add, subtract domains and interventions as is appropriate, depending on the characteristics and the features of the pandemic when it turns up. We don't know yet exactly what the pandemic domains will be. This is one possible construct. There's certainly interest in the question of whether outcomes would be better in patients who may have impaired enteral absorption to receive their neuraminidase inhibitors intravenously rather than enterally. There's a lot of interest in convalescent sera as soon as it becomes available as a potentially valuable therapeutic intervention in patients with pandemic influenza. But REMAP-CAP already has a ventilation domain and it already has a steroid domain. Our expectation is they will continue to roll through a pandemic, generating evidence about whether or not which type of ventilation strategy is best and whether or not steroids influence the course of pandemic pneumonia. So REMAP-CAP will soon be recruiting in the interpandemic period, and that means that it's practiced. Its protocol, its CRF, its data management are all prepared and in place. So it's pre-planned. And the ethical and other approvals that will be necessary for a pandemic will be obtained as soon as possible. So it's pre-approved. By way of conclusion, pandemics are a regular occurrence. We've had 12 of them in the last 280 years. An influenza pandemic is still regarded as the event most likely to kill more than 10 million people. And research can change the trajectory, particularly the capacity to conduct randomised controlled trials during a pandemic, saving lives through research. But only if that research is pre-planned, pre-approved, and practiced. The aphorism is think global, act local. It very much fits with the overall theme of this meeting. You never know when a pandemic is going to turn up, and now is the time to get this right. Sprint SARI is currently in a consolidation phase, but we will soon be looking for more countries and more sites. REMAP-CAP is a logistically complex trial to try and execute. It's been a slow process. We have enough at the moment with the sites in Europe, in Australia, and in New Zealand, and hopefully soon in Canada. But as we work out how to roll REMAP-CAP, we will definitely be looking for sites either to participate in the interpandemic period or even just put through your IRB, the pandemic domains, so that in the event of a pandemic, we're in the place where as many patients as quickly as possible can be enrolled in randomised controlled trials, and we can use and generate evidence during the pandemic to improve patient outcomes. Thank you very much for your attention.